Welcome to the Lymphoma Research Foundation's update on T-cells lymphoma webinar. My name is Jimena, and I'll be your operator for today's call. During today's call, you will hear from an expert speaker, and you will have an opportunity to ask questions. If you have questions during today's presentation, you can ask them at any time in the Q&A box on the webinar. As a reminder, this webinar is being recorded. At the end of the program, a link will appear on your screen. Please follow this link to complete an evaluation of this program. If you are listening by phone, this link will be sent to your email at the end of the webinar. And now, I'm pleased to introduce Jessie Brown. Jessie Brown is the Associate Director of Patient Education and the Lymphoma Research Foundation. Welcome, Jessie.
Thank you, and thank you to each of you for taking the time today to join us on Update on T-Cell Lymphoma webinar. We'd like to thank our sponsors of this webinar, Pfizer and Seattle Genetics. Before I turn this program over to our speaker, I want to briefly share information with you on the Lymphoma Research Foundation. Access to expert disease information is so important, and we are thrilled to be able to bring you this educational program. The Lymphoma Research Foundation is the nation's largest nonprofit dedicated exclusively to lymphoma. Our mission is to eradicate this disease through investment in the most promising lymphoma research and to serve those impacted by lymphoma through quality education and support opportunities. As we continue to make progress in advancing lymphoma research, we also want to ensure that you have access to the latest information about your disease. The Foundation provides comprehensive, disease and treatment-specific resources, programs, and services, all of which are offered free of charge and have been reviewed by lymphoma experts. Most relevant to today's call, LRF offers a variety of lymphoma-specific resources, many of which you can access at the bottom of your screen if you're utilizing the web link, or via LRF's website at lymphoma.org if you're on the phone. The LRF helpline can answer your specific questions about lymphoma, as well as discuss relevant treatment options and clinical trials. We also offer the Lymphoma Support Network, which is a one-to-one peer support program for people with lymphoma and their caregivers. We offer a variety of publications that have been reviewed by lymphoma experts to ensure you have access to the latest lymphoma information. This includes dedicated fact sheets on T-cell lymphomas and a lymphoma care plan to help guide patients and their physicians discuss and document the cancer experience. Our mobile app, Focus on Lymphoma, which has recently been updated, is an award-winning app that provides patients and caregivers access to comprehensive content, as well as unique tools to help manage your disease. Finally, we've launched our COVID-19 Learning Center to support lymphoma patients and caregivers through this challenging time. To learn more about T-cell specific resources, or if you have questions regarding what you heard about today, you can reach out to the Lymphoma Research Foundation through our website. We have a wonderful program planned for you today. I'm honored to introduce you to Dr. Nora Bonani. Dr. Bonani is a hematologist and oncologist at Mayo Clinic in Rochester, Minnesota, where she's an assistant professor of medicine. Thank you, Dr. Bonani, for speaking at our program today. I will now turn the talk over to you.
Thank you. Thank you all for asking me to give this presentation. This is a topic that I have a huge stake in because that's my area of interest research, and I spend a huge amount of time trying to bring answers to our patients through education, through research, and so I am very happy to be here and to have you may have. So these are the topics that I will be addressing. First, I will go through some biology basics, basically, of T-cell lymphoma. Some slides will be on the incidence and the classification. I will go over what's needed for diagnosis and staging, over the outcomes as well, and the main therapies when the patient has a new diagnosis. And if the disease comes back, what do you do? And then hopefully I will have enough time to go over some of the specific subtypes of T-cell lymphomas that are not as common. So let's start by, the biology of lymphoma. So lymphomas are the consequence of abnormal development of some of the lymphoid stem cells, okay? And these lymphoid stem cells will lead to various T subtypes, and that can be B lymphocytes, T lymphocytes, or natural killer cells, and that's how we end up with the various types of lymphomas. This slide mostly illustrates the distribution of the lymphatic system. As you may know already, our lymph nodes and lymphatic system is through the whole body. It's distributed in the lymph nodes are distributed in various areas that you can see here. And in the middle here, between the chest and the abdominal cavity, you see this wiggly line. That's the diaphragm. It's a muscle that falls between the chest and the abdominal cavity, and it is referred to frequently by your oncologist because we use that in our station. Actually, the spleen, which this tiny bean-like image right here is right under, it's on the left side, hidden underneath your ribs. And when the spleen is basically a lymph node organ as well, it is often affected in lymphoma. We always will look at it and see whether it is involved. Okay, so now that we covered some of the basics, lymphomas are a huge number of diseases. It's not one disease. So whenever I see a patient the first time in my clinic, I usually share this information that there are about at least 100, if not more, types of lymphomas. They are divided in Hodgkin lymphomas. These are, the typical lymphomas that are seen in much younger patients in their late teens to 20s. The remaining types of lymphomas, anything that is not a Hodgkin lymphoma, is called a non-Hodgkin lymphoma. The non-Hodgkin lymphomas are divided into two big subtypes, either B cells, B as in boy, that's the lymphocyte that makes that lymphoma, or T lymphocytes, or T cell non-Hodgkin lymphoma. Those are the T lymphocytes that are affected or are behaving abnormally. This slide mostly shows the incidence of non-Hodgkin lymphoma in the U.S. population based on the latest survey of cancers within the U.S. You can see that in both women and males, the non-Hodgkin lymphoma incidence is about 80,000, with 44,000 in male and 36,000 in females. This is in comparison to some of the most common cancers that we see, such as prostate cancer in males, with a number of, let's say, 270,000 cases, while in females, the most common cancer is breast cancer, as you may know, with a high number of 290,000. So from 290,000, non-Hodgkin lymphoma is 36,000. So in comparison to other types of cancers, non-Hodgkin lymphomas are relatively rare. In Western countries, peripheral T-cell lymphomas, and I will go over what peripheral T-cell lymphoma means a little bit later, but they do represent about 15 to 20% of all aggressive lymphomas, 5 to 10% of all the non-Hodgkin lymphomas. And what I tell my patients is we see roughly 3,500 to 7,000 new cases a year. So it is relatively rare. Some of these lymphomas, when they present in the community, they may not have seen a case because it's so rare. In Asia, the numbers may be higher, particularly related to EBV or Epstein-Barr virus or the monovirus. So we see in Asia more commonly the NKT cell lymphomas that are EBV related or monovirus related. This slide mostly shows you the distribution, the number of how many subtypes in the latest classification, which we call the World Health Organization in 2016. And as I mentioned, there are a total of about 99 subtypes of lymphomas. probably more by now as the technology is evolving. We are discovering more and more. But you can see that there are about 30 subtypes mature T and NK cell lymphomas. So if you look at the normal naive T cell, based on the exposures it has through cytokines or chemicals that will lead to this T cell to develop into various subtypes, that may explain why we see such a variety in T cell lymphomas. The T cell lymphomas are not created equal, and it is reflected in this slide that shows the various subtypes of T cell lymphomas. This list is not 100% comprehensive, but it does reflect the varied biology of this lymphoma. Some of these are aggressive, some are relatively indolent, and can even sometimes be observed. So not all T cell lymphomas are created equal, and not all of them are necessarily bad. So it is very important to know exactly what T cell lymphoma the patient has, because that will determine how we manage the disease. Whenever I'm dealing with a disease that has a lot of subtypes, it always helps me to put things into buckets and helps me think about the case and helps me decide what will be the best approach. The way we divide the T cell lymphomas is whether the lymphoma involves the lymph nodes, and that's what we call nodal T cell lymphomas. Okay, let me go back. I actually touched the slide by mistake. So nodal T cell lymphomas, and these are the most commonly seen here within the U.S. Extranodal is any disease that falls outside of the lymph node system. And these are the disease that involve the nose area, the diseases that involve the spleen, or that involve the gut, like the edo or the medo involve the gut. And there are lymphomas, T cell lymphomas, that affect purely the skin. So the most common is mycosis fungoides or Sézary syndrome, but there are multiple other subtypes with different biology and aggressiveness. Some of them are not aggressive, some are more aggressive than the others. And then there are the T cell lymphomas that fall within the leukemia form, and those are more rare in the U.S. We don't see them as frequently as in areas that are more endemic to HTLV1, for example. So this is the adult T cell leukemia lymphoma, or others more aggressive leukemias. This slide mostly shows the distribution of the various T cell lymphoma subtypes based on a retrospective study that looked at the incidence of each subtype that we see here. As you can see, the peripheral T cell lymphoma NOS are the more common subtypes, about a quarter of the types, then followed by angioimmunoblastic T cell lymphoma. After that, you can see the anaplastic large cell lymphoma. These are the two ones here. The remaining subtypes are relatively more rare. This illustrates the incidence of peripheral T cell lymphoma, which appears to be possibly on the rise. So if you look here at the years, as we are moving through the years, we are picking up more and more on the T cell lymphomas. I do think that it is most likely a reflection of having better technology that is available to our pathologists to better recognize these diseases. In the past, they were often misdiagnosed and fell under auto diagnosis rather than under T cell lymphoma. So some general features. T cell lymphomas are more commonly affect older patients, The median age in general is about 60 years. However, there are some subtypes, for example, the anaplastic large cell lymphoma, the ALK-positive anaplastic large cell lymphoma, which affects preferably younger patients, the hepatosplenic gamma delta T cell lymphoma as well, younger men in their 20s or 30s. It is more common in men than women with a ratio of 2:1, often presents by affecting several lymph nodes. So it's generalized in large lymph nodes. And when patients present with the typical nodal T-cell lymphomas or the hepatosplenic T-cell lymphoma, they tend to present relatively sick with quite a bit of symptoms. So that's what we refer to as systemic B symptoms: fever, chills, night sweats, and weight loss. And it is very common actually at presentation. This mostly shows you how does the disease present. More commonly, it affects the lymph node system. Sometimes it may be involving the nodes, but also may fall within other organs outside of the nodes. Enlarged spleen and liver can be seen in about 24 to 17% of the patients. The skin and the gastrointestinal tract are the most commonly extranodal sites that are involved. This slide is a bit busy, but it just shows by histology how this disease is present or how advanced the disease is. So, for example, you can see the predominance in males. So about 65% affects males, and most of the time, more often than not, it presents at an advanced stage 3 or 4. This shows the frequency of bone marrow involvement. It is, in a third of the patients is involved. And this talks about the IPI score, which I will talk about in the next few slides. So how do we make a diagnosis? You put in 3 asterisks next to the biopsy because that's how you are going to determine 100% what's the diagnosis. No imaging will tell you what type of lymphoma you have. Only a biopsy and looking under the microscope will tell you what lymphoma the patient has. But I also would like to emphasize that this is a diagnosis where we absolutely need an excisional biopsy, if at all feasible. If the lymph node or the mass that the patient has can be removed, meaning taking a big chunk of it, that will be the ideal case scenario. Because, and I'll tell you the reason why. It is notoriously very difficult to diagnose, and our pathologists often struggle to make this diagnosis, despite even the technology that we have today. So whenever I see a biopsy that is done, that is taken more than a week, I know in my mind that is probably a T-cell lymphoma, because typically I hear back from my pathologist within 3 to 5 days. If it takes any longer, I know that they have difficulties making the diagnosis and that it is probably a T-cell lymphoma. So whenever possible, an excisional biopsy is favored. The remaining staging workup includes some lab work, radioactive sugar PET-CT scan, so that's what we call FDG PET-CT scan. This is a scan that goes from head to below the knee or to the toes. It gives us a general idea of where the lymphoma is. Bone marrow biopsy is often needed to complete the staging workup, and depending on the presenting symptoms, if let's say the patient has a blurry vision or double vision or headache, we may need to do a brain MRI or even a spinal tap to assess the spinal fluid to make sure that there is no lymphoma in the central nervous system. This is a few examples of how a PET-CT scan looks like. So anything that lights up bright, like in the white one or the colored one, is usually lymphoma, except the brain. Brain typically lights up because it avidly takes up the sugar. But the kidneys, the brain, and the bladder will light up. Anything else could be inflammation, infection, or lymphoma. And I'm telling you that because not anything and not everything that lights up is necessarily a lymphoma. So only a biopsy can tell you 100% that it is a lymphoma. So it helps in the context of a lymphoma. You see something that lights up, you assume it is a lymphoma. And it is a test that is helpful both at the staging workup and following response to treatment. So we tend to do it at baseline, before treatment, and then we repeat it after a few cycles to determine that the patient is having an appropriate response. This is the staging system that we use, and I will go over it. So this dotted line right here in the middle, that's where the diaphragm falls. And you will hear us talking about above or below the diaphragm. Basically, stage 1 is disease in a single lymph node or lymph node region, so one area that is involved. Stage 2, 2 or more lymph nodes in one side of the diaphragm, either above or below the diaphragm. That will be a stage 2. Stage 3, when you have involvement both above and below the diaphragm, in both sides of the diaphragm, basically. Stage 4, when it's widespread, when there is involvement of other organs outside of the lymph nodes, bone marrow involvement is considered as a stage 4. Sometimes you may hear a stage with an A, it's without B symptoms, or B with B symptoms. The B symptoms that I explained before, meaning weight loss, fevers, and explain drenching night sweats. So that's what it means. That's what the B means. I always tell my patients that a stage 3 or stage 4 in lymphoma is very different than what it means in solid tumor, for example. If, let's say, lung cancer, stage 4 lung cancer, has a different meaning than in lymphoma. Some lymphomas, we are still able to cure the disease even at stage 4. This is how a lymphoma looks like under the microscope, and these are the things that our pathologists have to look through to provide us with a diagnosis. They basically look at the tumor under the microscope, and they need to look at, I apologize again, they need to look at the structure of the lymph node and where the abnormal lymphocytes are located. Then they start staining the cells with various stains or tumor markers to help narrow down the diagnosis. So this algorithm, and I'm sure it's very simplified, this is what the pathologist looks at various steps to guide them for a diagnosis. So, okay, now we have a diagnosis of T-cell lymphoma. Okay, you are told you have a diagnosis of T-cell lymphoma, so now what? What do we do? The things that are taken into account where your oncologist decides how to treat. First is, what type of lymphoma do you have? As I mentioned previously, not all T-cell lymphomas are created equal. They are not treated and managed similarly. Some clinical characteristics are important for us, particularly the stage, the patient's age. So if a patient is much young, a young patient in their 20s, we may treat differently than if we are treating a patient that is 75-year-old, because some aggressive therapies may not be tolerable to a much older patient. How functional and what other medical conditions that are ongoing, because that will determine some of your treatments. Some medications may affect your heart function, so sometimes we may have to stay away from it. If a patient has diabetes and they have a peripheral neuropathy, that is something that we need to consider, because some drugs may cause some peripheral neuropathy. So what are the things that we look at that may affect the prognosis or the outcomes overall? I will go over a few of these things that we look at. So the type of lymphoma matters. Some types do better. So for example, the red line on the top here for the common subtypes, that's the ALK-positive anaplastic large cell lymphoma. This is a highly curable disease, and you can see that most of these patients are, more than 70% of the patients actually, more like 80% or more are cured. The other subtypes don't do as well, but there is a various degree. The PTCL NOS does not do as well as the remaining subtypes. If you look at the uncommon subtypes, for example, the primary cutaneous anaplastic large cell lymphoma, the yellow line here, it is a very indolent disease. They do very well. Patients often do not die from their disease. Actually, sometimes we may even observe if it is just a small spot that is affecting the patient. While other diseases, for example, the hepatosplenic T-cell lymphoma, unfortunately, the outcomes are not as good. I mentioned earlier the International Prognostic Index. This is an index that is we developed from various clinical characteristics and lab tests that, when put together, gives us an idea on how aggressive the disease is and has value in prognostication. So the age of the patient, when the patient is older, the lactate dehydrogenase, this is, and I always call it a non-specific lymphoma marker. When it's elevated, it suggests just tumor burden, basically. The performance status is important, the stage, whether a more advanced stage, and the number of extranodal disease sites are relevant. So we give 1 point to each one of these, and then we sum it up together for a total score ranging from 0 to 5. 0 is the best score. 5 is, the worst score, basically. So how does the IPI affect outcomes in T-cell lymphoma? This slide mostly shows that those with a lower IPI tend to do better in terms of 5-year overall survival in comparison to those with the highest IPI. So you go from 50% to 11% for those with higher IPI, for example. And this slide illustrated this graph here. So the yellow line right here, 0 to 1, they seem to do best in comparison to those with an IPI of 4 to 5. That is the red line right here. So how do we manage T-cell lymphomas at diagnosis? So when I see a patient in my office, how do I treat it? What are the things that go through my mind to help come up with a treatment plan? So the goals of therapy, so what we aim is potentially cure. Unfortunately, we do see, particularly in the very common nodal peripheral T-cell lymphomas, we see frequent relapses. However, as I mentioned earlier, some have high cure rates, so some diseases are highly curable. The goal is to maintain quality of life as much as we can through cell treatment and to minimize toxicity of therapy. And, how do we assess response? We go by how the patient feels, so improvement in symptoms. I often tell my patients, if you are sick from your lymphoma, chances are you're going to feel better once you start chemotherapy. I know it is counterintuitive, and you hear all kinds of things about how badly the chemotherapy may affect the patient, but it is true again and again. Whenever I see a very sick patient, I tell them, next time I see you walking through my door, you're going to be feeling much better, because these lymphomas can make the patients very sick. And we do a lot of things behind the scenes for our patients not to have significant side effects. So, the old days where people were very sick from their chemotherapy is not the case anymore. We have some very potent supportive care therapies that help with symptoms. Okay, the other thing that we go by to assess response, so shrinkage of the enlarged lymph nodes. So if the patient came in, they felt a mass in one or multiple lymph node areas, they're going to feel them shrink. And that can happen sometimes rapidly within a cycle or so. We also follow response by using PET-CT scans, so imaging studies, which we usually repeat after 2 to 3 cycles to make sure that they are responding appropriately instead of just putting the patient through treatment unnecessarily. And more often than not, we will see a response. Things that you will hear in regards to response to therapy. So these are the things you're going to hear: complete remission, and that means when the disease is completely gone, or so enlarged lymph nodes, they have shrunk tremendously that they are almost gone. Partial response, when there is a response, but it's the lymph node, the enlarged lymph nodes, or the tumors are only partially gone. So they shrank by half or more. That's what we call partial response. Stable disease, when the disease has not changed inside the tumors, did not necessarily shrink, they stayed the same, did not get worse. When they get worse, that's what we call progression of disease. And then you're going to hear relapse or refractory. When a refractory is when the disease does not respond to the treatment that you're given. Okay, so this is what most oncologists will be considering for the treatment of peripheral T-cell lymphoma. This is a complex algorithm, but this is in the NCCN guidelines that most of us follow nationwide. Mostly want to highlight this red square here. As you can see, a clinical trial is a preferred treatment option for any peripheral T-cell lymphoma, and I will emphasize that over and over again, and I will explain to you why is that so important. Okay, so when I see a new diagnosis of a peripheral T-cell lymphoma, this is how I think about it. If the patient has an aplastic large cell lymphoma, they fall under different buckets because their treatment, their initial treatment is different. If they have other subtypes of T-cell lymphoma, like angioimmunoblastic T-cell lymphoma or PTCL-NOS, then I ask myself, is the disease CD30 positive or negative? CD30 is a tumor marker that is present on the surface of the cell. It is uniformly present in all anaplastic large cell lymphomas, so all of them will receive a drug called BV or brentuximab vedotin that targets CD30. So that is not even a question. Every patient will receive BV as part of their treatment unless there is a clinical trial that is appropriate for this patient. If it is not an anaplastic large cell lymphoma, then the question is it CD30 positive or negative? If it's CD30 negative, then we are treating with CHOAP. If CD30 positive, then consideration can be made for including brentuximab vedotin in their initial therapy. And I will go over that more in detail. And you see here in the bottom that there is consolidation with high-dose chemotherapy and autologous stem cell transplant in most of these patients if they achieved a complete response at the end of therapy, and I will touch upon that in a moment. So again, CD30 negative disease, the treatment is a combination chemotherapy in the setting. So if there is no clinical trial, so first a clinical trial, if there is none available to you, then it's a combination chemotherapy in the form of CHOP or CHOAP, and I will tell you why I say one or the other. It combines these various drugs, including prednisone, which is an integral part of your treatment, and these chemotherapy drugs are given IV every 21 days or 3 weeks in general for 6 cycles, even for the earliest stages. The etoposide is added for some patients and not necessarily all patients. There is some benefit in adding it. So these slides mostly show the overall survival in those who were able to receive the etoposide on top of their chemotherapy. So you can see there is a significant improvement in survival when etoposide is added. However, older patients are not able to tolerate a more intensive therapy or intensification with the etoposide because they tend to have more lower counts and more infections, and as a result, if you were to add this, you end up with more delays in therapy, and as a result, that benefit can be lost. So the benefit was lost in the patients that were more than 60 years old. So I tend typically to take it on a case-per-case basis. I usually give it up to 65-year-old to a patient that is 65 years old, and I will not give it after that because I think I will do more harm by giving the etoposide than try to push it on my patients. And you know, our first goal is to not do harm. That's an important thing to keep in mind. Okay. So many will use the CHOP or CHOAP combination and will consolidate with an autologous stem cell transplant in first remission. Okay. The data that we have for the transplant is not based on randomized studies, and there is a lot of talk right now about considering doing a randomized study to see whether truly the stem cell transplant is beneficial. But there is some retrospective data that supports its use, but it is a bit controversial at this time. Some remissions may be durable, and we may even see some cures. And, you know, we tend to see worse outcome for the higher stages, the high IPI scores, and in elderly patients because they are not able to tolerate as intensive of a therapy as we want to throw at them, basically. This slide mostly shows the benefit of transplant at first remission. So you can see here in the top line, these are the patients who received transplant at first remission, so finish the first treatment, first chemotherapy, and that's what we call the first remission. And you can see much better survival in those patients. The same here in this yellow line, those who had complete response in angioimmunoblastic T-cell lymphoma did best. The same here. This is more recent data based on a retrospective series that was just reported. Again, there is a benefit. However, the studies are retrospective, meaning they were not done as part of a clinical trial, and as a result, there are often biases linked to retrospective studies. So this data may be true, but we don't have a proof yet that it is true. Only a randomized clinical trial can tell us whether it's truly beneficial. We still do it on a case-per-case basis. We still recommend it at first complete remission. So now we are going to switch in gear to those with CD30 positive disease. So the anaplastic large cell lymphoma, for example, but other subtypes may have positivity for this tumor marker. So again, if you have a clinical trial, that will be your favorite option because we think that the best way we can serve our patients is through a clinical trial to bring them hopefully better therapies than what we currently have. Outside of a clinical trial, then the standard of care is the A-CHIP or the BV chip. BV stands for brentuximab vedotin. The rest is like the CHOP chemotherapy I mentioned earlier, except we remove the vincristine because the vincristine and the brentuximab vedotin or BV have similar toxicity, particularly peripheral neuropathy, so injury to the nerves causing numbness, tingling, burning sensation. So we don't want to give typically two drugs that cause the same side effects or adverse events. So we drop the vincristine for the brentuximab vedotin. It is also given every 3 weeks for 6 cycles. Brentuximab vedotin is an interesting drug. It's a newer drug. It is basically an antibody that is conjugated to a chemotherapy. So it is linked to the chemotherapy. It binds to the tumor marker CD30 on the surface of the tumor. It gets internalized. Then it releases the chemotherapy warhead that is linked to it. And the chemotherapy is the one that destroys the cell. So it is a very targeted therapy, and we've seen very good outcomes with it in patients with CD30 positive disease. This is the Echelon-2 data that showed benefit of adding the BV to the rest of the chemotherapy in patients with T-cell lymphoma, both for overall survival and progression-free survival. I would like to point out that in this study, this study was enriched with patients with anaplastic large cell lymphoma. It was a mandate to lead to approval of this drug in Europe. So this is a group of patients that tend to do well, and we saw very good results with it. In terms of clinical trials, what's hot right now and what's going on in the U.S. in terms of clinical trial in the frontline setting, meaning someone who has not been treated yet. This trial is nationwide currently enrolling in CD30 negative peripheral T-cell lymphomas. It's basically 3 arms. The patient can end up in any of these 3 arms, either in the standard of care arm where they will receive CHOP or CHOAP chemotherapy, or they will receive the standard of care plus something else. And that something else can be duvelisib, which is an oral medication, or azacitidine, also an oral medication that is added to their therapy to see whether we can see better outcomes by adding something extra. Because I think we still can, we can do better than the CHOP or the CHOAP chemotherapy. Okay, and I would just say that currently this trial is enrolling at Mayo, so if it is enrolling elsewhere as well. So please let us know if you will be interested in such a trial. Okay, so how do we manage the disease when it comes back, when or if it comes back? Typically, we look at the patient and see whether they received prior transplants and whether they are eligible for a transplant. If they have not received a transplant and they are eligible for a transplant, then we may consider it. Also, we look at the clinical trials that are available to the patient. But in general, if no clinical trials are available, we look at more single agent therapies rather than very aggressive chemotherapies. And in some cases, in the younger patients, in the more rare diseases, more aggressive diseases, we may consider allogeneic stem cell transplant. That's the donor transplant that should be considered in a select set of patients. This graph mostly shows the outcomes for example, angioimmunoblastic T-cell lymphoma with some of the FDA-approved therapies. So the outcomes are usually overall response rate, so response in about 30% of the patient in general with these drugs. The CR is a complete response rate. Some of these patients will have a complete response with some of these drugs. It is interesting to see that the romidepsin and the belinostat are highly active in angioimmunoblastic T-cell lymphoma and the lymphomas that are called of TFH phenotype. and they have tumor characteristics that makes them highly sensitive to these two drugs. So, the way things work, when we see that a drug is active, we tend to try to combine it with other things to see if we can get better results. And, keep in mind this image of responses, and then go to this one here. When we combine these various drugs together, you can see much higher response rate. We are now talking about the response rate of azacitidine and romidepsin of about 70% and a much higher complete response rate. Similarly with other drugs. Of course, when you combine things, there will be some added toxicity. The question is to find the most effective combination and a safe combination at the same time. We don't want it to be excessively toxic to the patient. So many of these drugs have been studied in combinations, and the jury is still out right now of what will be the next combo that will be FDA approved moving forward. So I will share with you a few exciting newer treatment strategies. Valemetostat is a new oral EZH1, EZH2 inhibitor that is currently under study. It is not yet approved, but the studies are very exciting. A phase 2 trial in acute T-cell leukemia lymphoma showed very good responses in these very difficult to treat diseases. Actually, in Japan, this drug will likely get approval for the treatment of the acute T-cell leukemia lymphoma. The phase 2 study for PTCL has recently enrolled. Actually, it enrolled very quickly. We have currently still 2 patients in our clinic on this drug, more than 1 year out, very well tolerated. We are still waiting on that data, but based on the initial phase 1 study, the overall response rate was 70%, which was, extremely high in comparison to any other drugs that we see. So, but we'll see what the phase 2 shows, because when you enroll more patients and from various institutions, we want confirmation that it is indeed true. So time will tell. Okay, other therapies, we are basically trying to affect the immune system to try to fight the cancer itself. There have been various strategies, and you may have heard of all the immunotherapies that have been approved in other types of lymphomas. In T-cell lymphoma, we are a bit behind because T-cell lymphoma is a very unique cancer, because in general, it's going to be the T cells that are going to kill the T-cell lymphoma. So basically, T cells killing T cells can be sometimes problematic. So we have been behind for that reason, because some of the immunotherapies, we saw more side effects and issues with it. This one is an interesting immunotherapy. It basically activates the anti-tumor activity by blocking the "don't eat me" signal. Okay, so some tumors will cover themselves with a tumor marker that will tell the immune cells, don't eat me, just leave me alone. Simplistically, basically what we do, we block this, and then the tumor becomes more available for destruction by our macrophage immune system. They did the phase 1 study. They saw initially some signal of activity in T-cell lymphoma and cutaneous T-cell lymphoma, with an overall response rate, trying to see here. So in mycosis fungoides, the response rate was about 26%. In peripheral T-cell lymphoma, about 22%. We are still waiting on the data from the phase 2 study that included both peripheral T-cell lymphomas and CTCL. The numbers that I mentioned are really in small numbers. Other immunotherapy clinical trials, this one was done here. I did lead this study. We did see a response rate that is similar to other drugs that are currently FDA approved with a response rate of 33%. However, we saw a shorter duration of response, and in a portion of the patients, 4 out of 12, we saw rapid progression of disease. And that's what I was mentioning. You are stimulating T cells that are going to attack T cells that sometimes may stimulate the cancer. So the question is to find ways to better use these immunotherapies in patients with T-cell lymphoma, and we are currently actively working on that. These are the clinical trials that we have currently ongoing at Mayo Clinic in the relapsed refractory setting. I will highlight mostly the first trial, which is quite exciting for me and for our patients. This trial uses a virus that is genetically modified to turn cold tumors into hot tumors, meaning these tumors would become more visible to the immune system. So basically, you inject the patient, it's a one-time infusion of this genetically modified virus, which is typically cleared from the system very rapidly. And then that virus actually will infect the tumor specifically, will kill the tumor, and as it is killing the tumor, it is at the same time stimulating the immune system through interferon beta to better see the tumor. And that's how you see further propagation of the response systemically. So currently, in the highest dose level, we saw 5 out of 10 responses in our patients with 2 complete responses, and some of these responses were long-lasting. We basically have one patient who is disease-free more than 30 months out, and I just saw a patient last week who is now more than 14 months out. This is actually the patient. Angioimmunoblastic T-cell lymphoma relapsed quickly after getting her R-CHOP chemotherapy. She received the oncolytic virus, and she is now disease-free more than 14 months out at the moment. This is another patient. He had a higher disease burden, and you can see the after scan where most of these lymph nodes are gone. So this is extremely exciting. We are looking into enrolling more patients to make sure that these responses that we are seeing are real. So if interested, please reach out to me. We will be looking to enroll more patients. So I'm going to spend a few minutes talking about rare subtypes and unique presentations. The breast implant-associated anaplastic large cell lymphoma. It is an uncommon but increasingly well-described entity that is linked to textured implants in women who had had a breast implant placed. Basically, 573 worldwide cases reported as of July of 2019, and the incidence of this type of lymphoma is 67 times higher than in the general population. Oftentimes, it is actually localized to the capsule because that capsule creates a lot of inflammation. And often it just starts there and it stays there, but sometimes it may go to the lymph nodes and spread outside of the capsule. This is how we manage it. We typically recommend complete surgical resection of the implant, the capsule, and any associated masses. For localized disease, if it's completely excised, you don't need to do anything. If it is unresectable or if it has spread, we may treat with additional chemotherapy as with any other type of ALK-negative anaplastic large cell lymphoma. A few slides on cutaneous T-cell lymphoma. These are the various subtypes of cutaneous T-cell lymphoma. Mycosis fungoides is the most common type. It represents about 50% of all primary cutaneous lymphomas. It is associated with some exposures, such as pesticide exposure, pharmine, painting, carpentin, petrochemical, textile, and some other exposures. It can spread to the lymph node system and other organs as well. It is more predominant in males than females, again. Median presentation is 55 to 60 years old. Overall survival is relatively good at 5 years, with about 90% are still alive at 5 years. It can present as patches, plaques, or tumors, sometimes just generalized redness of the skin, and that's what we call erythroderma. Usually limited to the skin, particularly the sun-exposed area, the sun-protected areas. It has a very slow progression, so oftentimes, waxing and waning skin lesions that we treat over several years. Okay, it comes as a clinical spectrum. Some patients may present with patch stage only. Some may have patches and plaques. Some may have pure tumors, and some may just have this diffuse redness of the skin. Itching is a very common symptom, bothersome symptom that affects quality of life in our patients. So we tend to spend a lot of effort to try to manage other associated symptoms with the skin lesions. These are some examples on how this disease can look like. So this is a patch. Plaques, usually they have a body, you can actually feel it. Tumor, it's something that is sticking out of your skin, and an ulcer, things that are ulcerated, can also be seen. The treatment is usually multidisciplinary. We work very closely with our dermatology colleagues and radiation oncology colleagues to manage this disease. We've spent a lot of time focusing on topical therapies initially, as well as light therapy, because they are very important for management of early disease. We tend to intervene with systemic therapies only in the more advanced refractory stages. This is what our NCCN guidelines recommend for skin-limited disease. You can see radiation and topical therapies are in the front line of management. And then at the later stages, you can see more systemic therapies that are, most of them have been approved for peripheral T-cell lymphoma. But, throughout the life of this disease management, we always combine skin-directed therapies and the systemic therapies at the later stages. I'm going to skip that slide in the interest of time. Okay, this is a clinical trial that we have currently ongoing at Mayo. It may be open, it is open elsewhere as well, so whatever works for you. But if you have stage 2B, mycosis fungoides or Sézary syndrome, this is a good trial to consider because each one of these drugs is actually quite active in mycosis fungoides or Sézary syndrome. The question is, will our patients benefit more from the combination? So this trial is currently open and enrolling. Please send me an email or call us if interested. Okay, this is a more rare subtype. It's the NK T-cell lymphoma. It's treated very differently. In general, combination aggressive chemotherapy and radiation therapy. And in the interest of time, I'm going to stop here and just say that, there is hope. we are getting there. Thanks to all the technology, evolving technology, we are learning more about these diseases and bringing more therapies to our patients that are highly beneficial. So we are finally seeing some progress in the management of this disease. So, in common diseases, participation in clinical trials should be a first choice, and treatment at a tertiary center is highly recommended. I'm going to leave you with my final slide, which has my contact information. Always happy to talk to you all and happy to help whichever way I can. And I will stop here. I'm sorry I went over a bit the time, but I would like to hear if you have any questions.
Thanks so much, Dr. Bonani. That was a wonderful presentation and so thorough. We do have a few questions that came in, so we'll go a little bit over the time, if that's okay with you, just to answer them. The first question is, I have had peripheral T-cell lymphoma twice and 2 transplants, allo and auto. What are the clinical trials if it should return?
Okay, so peripheral T-cell lymphoma, the patient had an auto stem cell transplant and an allogeneic stem cell transplant. We have a few trials that could be considered. I am trying to think whether the viral therapy trial will be, whether the patient will be eligible for it or not, because allogeneic transplant sometimes can be excluded. But, you know, yeah, go ahead. I would say it will be important that we look at the patient closely, look at, you know, organ function and everything, and based on the whole picture, then we decide what clinical trials will be more appropriate. So feel free to reach out to us, and then we can look into your case particularly.
Great, thank you. This person said, I was about to have my 5th round of gemcitabine yesterday for PTCL, but because I contracted COVID-19, it was rescheduled to December 23rd. Will this delay of 18 days cause any problems for me?
Yeah, this is unfortunately a very common scenario where our patients, you know, contract COVID, end up catching COVID in the midst of their chemotherapy. As I always tell my patients, first, do no harm. If we were to treat you while you are going through your COVID infection and suppress you further, you know, COVID can kill the person as well. So we typically favor giving you time to recover from the infection before treating you. We try to avoid as much as we can, you know, delays in therapy, particularly in T-cell lymphoma, but when we don't have a choice, we don't have a choice, unfortunately. So I think I agree with your providers. We would have done the same thing here. We would have delayed your treatment until you have recovered, because we don't want to cause you more harm than what you're already dealing with. We want you to recover from.
Great, thank you. The next person asked for mycosis fungoides specifically. Can you share if presentation on the skin or numbers from tests are most important when monitoring the progression or lack thereof?
So for the skin presentation, we usually rely on how you look. Basically, looking at your skin, that's the best indication. Sometimes we also look at blood markers, particularly if you have blood involvement with T cells, so we can monitor that. But more importantly is how you're feeling. If you're having worsening of your rash, if you're having itching, that's a symptom that we monitor closely. And few blood markers, but I tell you, clinically, that's the most important for mycosis fungoides.
Someone asked, are there any clinical trials available in Hawaii? And if you're not sure specifically, is there a good way this person maybe could find out that information?
I honestly don't know what's available in Hawaii. Maybe the staff at the LRF will be more helpful in answering this question because they tend to post many of the trials that are nationwide. Yeah, I am not aware. And
yeah. We do have a clinical trials information service. So for the person who asked that question, if you wanted to call our helpline number, a member of our helpline staff could definitely help look into that for you.
Okay.
We have a few more questions if you have time, Dr. Banani. The next question is, what is your experience in using BV in CD30 patients, especially in CTCL?
That's a very good question, Sue. It is truly a very good question. I typically don't use it necessarily in patients that are CD30 negative. However, there is some data that suggests, it's retrospective data, it was not studied prospectively, it's just data that we looked back that suggests that it doesn't matter how CD30 positive is the disease for the BV to be active. However, I don't know how true that is. So I would say I need at least some positivity to treat with BV. So that will be my answer.
The next question is, I recently read about fast track status for something called MT101 in relapse refractory CD5 positive T-cell lymphoma. Do you know anything about that?
It is in the early stages of study currently, so it's too early to say a whole lot about it. We don't have this trial. There is some background noise. We've been in discussions about this trial, and there may be more information in our national meeting that is in a week or so, or actually at the end of this week.
Great, thank you. The next question is, this person says their father has peripheral T-cell, ALK negative, getting treated at City of Hope. The cancer came back and doctor is recommending a clinical trial. Do you know of any that you recommend? And he also mentions that this person already has a transplant, has had a transplant.
Okay, so ALK negative anaplastic large cell lymphoma that came back, and if there is any clinical trial particular for this disease. So there are a few things that are of relevance here. So if the patient has received already brentuximab vedotin previously as part of their treatment, they may benefit from other therapies that do not include BV. So I had recently a patient that progressed but did not receive brentuximab vedotin prior to that. So in his case, I am considering giving the brentuximab vedotin in addition to other therapies for his treatment, then getting him to transplant. In the case of your father, he already got the transplant. I don't know whether they received CD30 or not. If they did not, they should get it, either alone or in combination. And any clinical trial that is available, for example, the virotherapy trial would be a consideration for your dad as well. So if interested, let me know. I emphasize again, it is a one-time infusion with close monitoring for a few weeks, and we typically know the answer whether it worked or not within a month. And at the 1 month mark, if it hasn't worked, then some other therapies could be considered afterward. So that's the benefit of that virotherapy clinical trial, plus the responses that we've seen. But we tend to look very closely at each patient and determine for eligibility. So there are things that we look at that will make a patient eligible or not.
Thank you. And we're just about out of time, so I'm just going to ask the last question. I know people are submitting a couple others, but we just have time for one more. So this person said, my husband had an autologous stem cell transplant in 2010 following 6 months of CHOP for AITL. Now there are some suspicious nodes on the CT. The results of the PET CT are inconclusive. What else can be done to confirm a diagnosis?
That is a very good question that we often face. So you do a PET-CT scan and you see some things that maybe are abnormal, but not very clearly. What I tell my patients, depending on the location, depending on how big they are, diagnosis is through biopsy. Sometimes the spots can be very deep and difficult to biopsy, or small and difficult to biopsy. What I tell my patients is time will tell, okay? If this is truly a lymphoma, it's going to express itself. Those tumors are going to grow over time. So I usually would say, let's sit on it and let's repeat a PET-CT scan in about few months, few weeks to several weeks to few months, and see where these spots are at the time. If they have shrank and gone, maybe it's just inflammation, because lymph nodes are meant to increase and decrease in reaction to infection, to vaccines and such. If, we see more, they are hotter, they are bigger, and maybe you're able to biopsy, that's the way to go.
Great. Well, so thank you so much, Dr. Bonani, for this wonderful presentation. For anyone who is listened in and asked if the slides will be available, this is being recorded, and the recording will be sent out to you in the next day or two. So be sure to keep a lookout for that. And if you want to get in touch with Dr. Bonani, she's very kindly put her email up on the screen here. So without further ado, I'd like to thank everyone again for joining us, and for our sponsors, Pfizer and Seagen, for making this program possible. Please remember, if you have any additional questions, like clinical trials questions, you can always reach out to our helpline at 800-500-9976. At the conclusion of this program, you'll also receive an email prompting you to complete an evaluation. We ask that you please complete this, as they're very helpful to LRF to ensure that we deliver the most useful and meaningful programming to you. And with that, I'd like to thank everyone for joining us, and to have a wonderful day.
Thank you, everyone. Thank you for joining, and I would say I am here for you guys.